Hi, I'm Paul Lurchard, a pediatrician trained in hematology, oncology, bone marrow transplantation. I have a special interest in MPS I, and today we're going to discuss the diagnosis of MPS I. Mucopolysaccharidosis type 1, or MPS I, it's a lysosomal storage disorder.
There's well over 50 lysosomal storage disorders that have been described. The overall incidence is about 1 in 8,000. There's 7 types of MPS disorders that have been described. MPS I is one of these. It's quite rare. The incidence is about 1 in 100,000. This slide describes the various types of mucopolysaccharidosis that have been described. MPS I was described by Dr. Gertrude Hurler in 1919. Dr. Shea also described a genetic disorder that was similar, was thought to be an independent disorder called Shea syndrome, but over time, as the genetic basis of this was determined, it was determined that these are actually the same disorder, but various phenotypes. Hunter syndrome is MPS II. Sanfilippo syndrome, there's 4 different genes that contribute to Sanfilippo. Morquio is MPS IV. Merto-Lemay, MPS VI, and Sly syndrome is MPS VII. And there's been another rare addition to this, MPS IX, but that's a very rare disorder. So MPS I, again, is lysosomal storage disease. The particular gene that's important here is alpha-L iduronidase, or IDUA. The inability of IDUA to break down glycosaminoglycans leads to the disorder. It accumulates storage material, including dermatan sulfate and heparan sulfate. It's recessive in its inheritance. There are several different phenotypes that have been described. The current terminology separates these into the severe form, which is Hurler syndrome, MPS I or MPS I-H, and then the attenuated aspects of the disease or phenotypes that were previously referred to as Shea or Hurler-Shea syndrome. So this is a continuum, but most of the patients that are born have Hurler syndrome. Again, the incidence is about 1 in 100,000, and the attenuated form is about 1 in 500,000. It's important to understand that MPS I affects virtually all the organ systems of the body. They can have hearing loss related to conductive issues. They accumulate fluid within the ear, but they can also have sensorineural hearing losses as well. They accumulate substrate in the soft tissues of the airway. It can make it very difficult to intubate these patients. It can also result in obstructive apnea. Skeletal deformities are prominent. They can affect both the ligaments and tendons as well as the bones themselves. Carpal tunnel syndrome is a common occurrence in these patients. It can also affect the abdominal wall, and they can have both inguinal hernias as well as umbilical hernias. Prominent in the disease, the severe form of the disease, Hurler syndrome, is developmental delay. And this could be a significant source of morbidity in terms of the disease. Corneal clouding can be apparent. Cardiovascular disease affecting both the function of the heart as well as the valves. And joint stiffness can lead to decreased range of motion and affects the standard of life of these patients. So there's quite a variety in terms of the severity of the disease. It's apparent on this slide. The patients that have severe disease, or patients with Hurler syndrome, untreated, generally die in the first decade of life. On the other side, some of the patients that have less severe disease can live relatively normal lives and have families of their own. But this is a continuum, and there are patients with more or less enzyme that's expressed and functional, and that affects how these patients are going to do in terms of severity of the disease. Pictured here are some of the symptoms that can lead to diagnosis for MPS I, the attenuated form of the disease. They tend to have difficulty in movement, stiff joints, can have some organomegaly as well, and hearing issues and airway issues and other difficulties as we discussed. Similarly, the patients with severe disease can have these same types of issues, but they tend to be more severe and present earlier in life, and some of these are more life-threatening. Pictured here are some of the aspects of the disease and the patients that have severe MPS I. The vast majority of them have coarse facial features. They have issues with their hands. The fingers can be broad. Range of motion of their fingers can be restricted. They tend to hold their hands in flexion. Umbilical and inguinal hernias can be apparent. Kyphosis or spinal abnormalities can be apparent very early in life. Some of these patients have issues essentially at birth. And corneal clouding is also a manifestation of the disease, although it tends to be apparent a little later in life. There's a broad variety of ways that these patients can present. Majority of them are picked up as having difficulties by their pediatricians and referred to geneticists, but some are diagnosed by neurologists or ophthalmologists or orthopedists based on the issues that they're having and how they come to attention. It's important to understand that many of these patients have a protracted time to have a diagnosis established, and that can be a significant disadvantage because identifying patients early and intervening early make a big difference in their overall outcomes. There is a correlation of the genotype and phenotype. The patients that have Hurler syndrome tend to have null mutations, nonsense mutations. So they essentially make no enzyme. The patients that have attenuated disease tend to have point mutations or missense mutations that can change amino acid and change the function of the enzyme. There's two alleles affected because this is a recessive disease. And so as one might imagine, there's a number of combinations that can be apparent as well. And that's pictured on this slide. There are two particular mutations that are important in those that have Hurler syndrome. It's a W402X and a Q70X, which are the most common ones, and most patients are either homozygous for one of those mutations or the other, or heterozygous for both. There are particular mutations that are associated with attenuated disease as well, but as one might imagine, various combinations of more or less severe mutations can make it difficult to establish, for instance, at birth, what the phenotype will be for a particular patient. The diagnosis is generally established with a blood sample. The blood samples are obtained, the white blood cells are isolated, the cells lysed, and functional enzyme activity is determined. If the enzyme assays suggest that there's very little functional activity, that would be consistent with the disease. However, there are circumstances where pseudodeficiencies are apparent, and the confirmatory testing for the disease would be to assess the accumulation of glycosaminoglycans. So in a pseudodeficiency, one would expect that glycosaminoglycans would not accumulate. And for those that actually have significant clinical disease, glycosaminoglycans should be high in the urine. It's also important to look at the genotypes. There is significant information apparent there that may help, for instance, in establishing the severity of the phenotype. In 2016, MPS I was added to the Recommended Uniform Screening Panel, or the RUSP. Since that time, a number of states have now been screening for MPS I, and patients can be determined to have the disease as a newborn. This is extremely advantageous because it's very clear that early intervention can make a difference in the outcome for the disease, and having the ability to diagnose these patients very early in life will not only save lives, but help in the achieving the best outcomes possible. In summary, MPS I is a rare autosomal lysosomal storage disorder. is part of the MPS family of diseases. If untreated, MPS I, the severe form of MPS I is lethal in the first decade of life. The gene that's important here is alpha-iduronidase gene, or IDUA gene. The absence of functional activity of the IDUA gene leads to accumulation of glycosaminoglycans throughout the body. The severe form is the more common form, called Hurler syndrome, and there are attenuated forms as well. Historically, many of these patients undergo an extensive diagnostic odyssey. They may see multiple specialists and pediatricians before the diagnosis is made. It's important to make this diagnosis as early as possible in order to obtain the best outcomes. And newborn screening is now available to us to be able to identify these patients essentially at birth. There are available therapies for this disorder, including allogeneic bone marrow transplantation, as well as enzyme therapy, and additional therapies will be available in the future.